Okay, thank you very much, Shiny. Good afternoon, good evening, everyone. Yeah, we welcome you to this afternoon where we are expecting to have a webinar. And particularly, this webinar intends to engage practitioners, policymakers, students, researchers on this subject of rational use of medicine. So this webinar has been organized in partnership between the Empower School of Health, the Ministry of Health of Tanzania, and the Global Fund. I am the moderator, Gladness Salema. I'm a senior lecturer from the University of Dar es Salaam, and my areas of specialization in terms of teaching, research, and consultants is in logistics and supply chain management, and my particular interest is in the health commodities supply chain. So I've published in peer-reviewed journals in the same subject, and I do consult in the same subject. Yeah. So we welcome all of you this evening, and we have Dr. Sangita, and we'll get her profile later before she starts her presentation. So our main agenda here is that we expect to be here for 1 hour, and ideally, I've already done some welcoming remarks. I'll also give you the housekeeping so that we are all aligned in this 1 hour. And then we have a brief talk about Empower and also about this partnership with the Ministry of Health and Global Fund. Then I will introduce our speaker, who is an expert in the area, and then we'll start the presentations and discussions. So we expect to have the question and answer session at the end. And during this session, we'll have Dr. Sangita, but we are also expecting Professor Andy to join us in the Q&A session. So I ask you, please, you can also use the chat box as we go along with the presentations. You use the chat box, just write your questions, and we'll try our best to pick them from there. And before we close, we have a poll, and this will be kind of a feedback to the organizers so that we can get to understand your feelings as far as this webinar is concerned. Yes. So this is key that we have to make sure that we mute our microphones and we turn off our videos, because we have an interruption as far as with the internet. And many of us are joining from different areas. Some are from the remote areas. So except for the presenters, I'm asking all the participants to turn off your videos and also mute your microphones, except during the Q&A sessions. And as I said before, please use the chat box to ask all your questions, your opinions, your recommendations. And also, please participate in the poll so that we can know more about your interest, for the future, as this is an ongoing activity as far as strengthening the capacity of the health commodities supply chain. But note that this webinar is being recorded, and it will be available in the Empower School of Health YouTube channels, so you can also check it there. Yeah, and the slide deck will also be shared with all the participants. And we expect you to give us the feedback, as far as how you felt about this webinar. And what is also important, that you also get your certificate of participation within 24 hours. Yes, please. So I'd like to say briefly about Empower School of Health. First of all, this is a capacity building organization with an experience in over 100 countries. And these are countries with different culture and also multiple languages. And the main focus is to strengthen the institutional and human resource capacity of global health and humanitarian programs through digital learning interventions. And in terms of focus, the main focus is mainly under three areas, that is leadership and change management, digital learning, public health procurement, and supply chain. And with the specific areas on global health leadership, global health supply chain, they've really provided support to development of interventions on COVID, HIV, TB, malaria, nutrition, and also in terms of new productions. You know, as we know that there are a lot of changes that we have as far as the pharmaceuticals productions are concerned, but they've also focused on medical lab diagnostic training and also health workforce strengthening as far as nurses, pharmacists, care, lab technicians, and supply chain experts. So it's the focus is in the health, and they've managed to also touch beyond just the supply chain. The main clients are UN organizations. Yeah, we have USAID, also the Global Fund, Bill and Melinda Gates. That is, we talk about the development partners, including MSH. Yeah, but we also talk about the government. As for this one, for example, they've been with the Ministry of Health since 2020. So the clients are quite diverse, from the public, that is government, from development partners, yeah, and they also have collaborations with different local institutions like the University of Dar es Salaam, the Medical Stores Department of Tanzania. So they have this kind of a diverse clientele. And in terms of their reach, that is, it has been able to develop and deliver nearly 1 million hours of capacity content to nearly 200,000 public health professionals globally. As we said, they are experts in digital learning. So they've been able to do that for our different stakeholders.
Preksha, can we have the poll, please?
Yes, Shiny.
Thanks.
So we have the poll, please. We are requesting you to just fill the questions according to your perceptions. It will just take a minute, please. No one is filling? Please. We're expecting everybody to fill this poll. Let us all fill the polls. Yes, thank you.
Where's the form? Can't see it.
Please, we are still, it's just 10%. Let us go try. Yes, yes, please. Because we want to be at least above 50% of the participants. Please mute your microphones and turn off the video to avoid any interruptions. Now 41%, 43%. %, yes, please. Can we have more people doing the assessment? This is pre-webinar that you need to get to understand, to get the basic or baseline information, please. Okay, we're almost there. It's 63%. 65%. 68. Yeah, 7%, I think we can, maybe we can end there, is 73%. Yeah.
We can.
So
Go
this
ahead.
is a pre-webinar assessment, and in terms of gender, that is male and female. We have more males, that is 69% of those who participate in the poll are male. And in terms of age, yeah, the difference between those who are below 30 years and those who are between 30 to 40 years is actually small, because the one that are below 30 is 39%. So majority are from 30 to 40%, that is 38%. Next. In terms of geographical region, 32% are from Tanzania, and 28% from Southern and Eastern Africa, and 22% from the rest of Africa, and then 19% any other regions that is outside Africa. Thank you very much. In terms of professionalism, 60% are pharmacists, and the remaining are non-pharmacists, so majority are the pharmacists. In terms of years of working experience, majority have less than 5 years. So this is very good, because we have young people who here who are going to upgrade their skills. And majority preferred to use emails in terms of contact. And in terms of membership, or whether you are an alumni or a staff of majority, we have 47%. These are members of the Pharmaceutical Society or Council of Tanzania. And 10% are alumni of Empower School of Health. And 6% are from the Ministry of Health. We have the International Federation of Pharmacists, this is 6%, and then others are 43%. So this is a group that we have, and it's interesting, and we expect to learn from each other. Thank you. Thank you so much for participating in the poll.
Okay.
So let me introduce to you our experts this evening. We have Dr. Sangita Sharma, who is a professor at the Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences. She's also president of the Delhi Society for Promotion of Rational Use of Drugs. In terms of her qualifications and certifications, she's an MD, pharmacology, and she also have an MBA from the Harvard Medical School Quality Leadership Program, and the Baldrige Excellent Framework for Healthcare Award. She's a certified external assessor for NOACs. Actively, she has been working in the forefront of promoting rational use of medicines, especially on antimicrobial use, medication suffered, quality in healthcare. She has a very diverse experience in terms of professionalism and also in terms of managerial experience, particularly in healthcare. And she has conducted about 1,300 workshops for capacity building and pharmacists. Yeah, and she also has a book which is on standard treatment guidelines, a manual for medical therapeutics, the 6th edition. The first edition was published in 2002. And several Indian states have adopted and adapted this particular book. So please, yeah, we can ask her also to tell us how we can access this important book. She's also serving on the ethics committee of several national and academic institutions, and she's a state node officer for MRI containment, Delhi State. Professor Sangita, I know you are there, and I believe you are ready for the presentation.
Yeah, thank you, Gladness, for your kind introduction. Thank you, I'm here, very much here. Please allow screen share. Okay, I can. Can you see my screen?
Yes.
Yes.
Okay, good afternoon, good evening to everyone. I'm told that we have a very diverse group here. Large number of people from various countries are attending this seminar today, webinar today. I will try to, justify my topic so that every one of you have a some take home message from this session today, because rational use of drugs is a very big diverse topic, and there are many stakeholders involved in using the medicines. So each stakeholder or each step in the medication management has its own problems and factors which introduce inappropriate use of these medicines. And this topic is important for all of us because if you want to talk about quality of healthcare, you need to talk about the safety of medicines and also the appropriate use of these medicines. So in today's session, we will learn about what are the factors and the conditions which lead to irrational use of medicines and errors seen in day-to-day practice, and what each stakeholder can do to promote rational use of medicines and along with these strategies. So I will try to enumerate all of these by giving examples. Maybe some of these examples are from India, but I believe the conditions in your part of the world region are also somewhat similar, because I also attend meetings of WHO Geneva. So there we get to know about what's happening in other countries. So, and I was going through the literature, also the problems which we face here in this part of the continent are more or less similar, and all of us have the same goal. The goal of the healthcare system is that we want to have a universal and equal access to reasonable healthcare, whichever part of the globe where we are. So we are all working towards the universal access to reasonable healthcare. So, and at the at this point of time, healthcare costs are escalating. So we need to be controlling the healthcare cost and provide healthcare at a affordable level, so that everyone has a access to the healthcare system. For this, we need to be using our resources effectively. Inappropriate use of medicines leads to wastage of scarce resources. We are all working with a fixed pocket size. The pocket size may change from country to country, but even the most developed countries, they are also working with a fixed pocket size. Their pocket size may be bigger. They may be spending bigger amount of money on healthcare, but all the more the challenges faced by them are more or less similar. And we find, despite having these healthcare goals, the existing public health system or the infrastructure is far from satisfactory. Many people do not have access to even essential medicines which meet their primary priority healthcare needs. Over the years, we have made a lot of progress, and the extent of healthcare coverage has increased. But this is a recent report published by the Lancet Global Health Commission on high quality health systems SDG goals, and there they have tried to show that although the coverage has increased, but the quality of use of medicine, the quality of care provided to patient is not to that extent. So that means we cannot be happy only about that we have covered this much of a population, but we need to ensure that the quality of use of medicines and the healthcare is appropriate, and it is leading to helps in reducing mortality and morbidity due to various diseases. This is another study reported by the Lancet Global Health was still in many places the diagnosis is not correct. So if the diagnosis is not correct, of course the treatment would also not be appropriate. So many of these conditions such as pneumonia, diarrhea, tetanus, still they are not treated appropriately. And here it shows the extent of irrational or lack of evidence-based guidelines and diagnostic accuracy in the lower middle income group of countries. And we find that people at this age in the global era of development, people are still suffering and dying because many medicines are not available, or they are not affordable, or they are unsafe, or they are wrongly used. Still, if you look at this, the distribution of burden, the cause of death in Africa and in Southeast Asia, still many people, children are dying because of these infectious diseases, where prompt diagnosis could have saved over 3 million lives every year. So that's the kind of the gain we will get if we use medicines properly. Now, a big question before us is, where is the problem? What is the problem? Nowadays, we cannot say that the medicines are not available. People are dying because medicines are not there. Or we cannot even also explain this situation that the medicines which are available today are of poor quality. Or is it that these medicines are used irrationally? And also, as I told you, limited resources also do not explain the shortage of medicines. So when we find that none of these are the reasons, so what do you feel about this? How do you improve the availability and accessibility to medicines? WHO has given this concept. If you want to improve the access to essential medicines, these are the essential medicines, as you know, are the medicines which are needed to meet the priority healthcare needs of the population. So for being able to provide these medicines to the patients, you need 4 pillars. These needs to be supported by 4 pillars, one of which is rational selection and use of medicines. And of course, you need these healthcare and the medicines at the affordable prices. You need reliable healthcare systems, supply systems to maintain availability of and accessibility to medicines, and sustainable financing. Piecemeal financing or inadequate financing is again this access framework will fall. Now, out of all these, we know today what I am going to talk about is that medicines definitely, for sure, they have a positive impact, but alone, making these medicines alone will not solve our problem, because most of the medicine use access related problems are because of their inappropriate use. And this health coverage, as I showed you, is not sufficient to ensure quality use of these medicines. There are many factors behind overuse, misuse, underuse, incorrect use, or use of expensive medicines. which unnecessarily leads to wastage of resources. And in many countries, injections and antibiotics are overused, they are heavily overpriced. And in this report again by the Lancet, they have said, they did this survey in 22 countries, and they found that only half of the patients are treated properly. For example, hypertension, only half of them, we have effective medicines available, but only half of them have been treated properly. So irrational use, inappropriate use of medicine is a major global problem, and WHO estimates that more than half of all the medicines are prescribed, dispensed, or sold, they are inappropriate. And above all, on one hand, prescription is inappropriate, and on the other hand, patients also do not take these medicines properly. They fail to take them correctly. So this is leading to a lot of wastage of resources, and besides resources, it has widespread health hazards as well. This is the slide again from the Lancet Commission. This is a very extensive report. I would like you to go through this report. It has many good findings in it. Although this is a figure from India, but I believe the situation is somewhat similar. More people are dying not because of the lack of access to medicines, they are dying because the medicines are not used properly. So therefore, the rational selection and use, if this leg of the table, access framework, is not working properly, the entire initiatives to bring medicines available, make it available for the people, will go waste. So what is I've been saying this inappropriate use or irrational use of medicines. What exactly does this mean? The rational use of drugs require that the patients receive medicines appropriate to their clinical needs. When they are needed, they get this. When they are not needed, they don't get it. But it is appropriate to their clinical needs in doses that meet their own individual requirements. For example, I can explain this by saying, if you need a syrup, if there is a child, you need a syrup. For an adult, you need adult dosage form. And in doses, many countries have seen that pediatric dosage forms are not available. So what they do is they break the tablet meant for adults. They break it into pieces and give it to children. So here we mean that in doses that meet their own individual requirement for an adequate period of time. If it is needed for 5 days, 1 month, or continuous on chronic treatment, then it should be available all the time and at the lowest cost to them and the community. Somebody is paying. In the public health system, usually people get this free, but from where do you get money for the public health system? It is from the taxations that we pay. So indirectly or indirectly, that we are paying for this cost. So that is why the rational use of medicines require that it should be at the lowest cost to them and the community. So if you look at the pharmaceutical management cycle, and if you look at the stakeholders involved, selection of medicines is the first step. If you don't have a good evidence-based system for selection of medicines, the entire framework will fall. But then you need to have a good procurement practices, processes to be in place, and then a role of distribution, supply chain management comes in, and that's how it reaches the end users, that is the patient, and these medicines are used. So all of this is governed by various policies, regulations, and laws. All the countries have some regulation or the other to regulate their use, but there are some it is always felt that the regulation is is as good as its implementation. If regulations are not implemented properly, that again the pharmaceutical management cycle will be disturbed. And all of us have a role, right from the policy makers who are designing the policies, regulations, laws, and looking after the public health management systems, then health administrators, managers, prescribers, pharmacists, nurses, patients, and communities. So I will try and cover, touch on the most important aspects, where each of the stakeholders can influence the use of medicines. We need to be worrying about these medicines. Definitely, the medicines save life, improve quality of life, but they can be dangerous. They can give rise to many adverse drug reactions and medication errors, which results in patient harm, and at the same time they are expensive. These medicines are misused, abused, overused. So that is why we need to be worrying about these medicines. And it has been seen that errors happen because 72% of the adverse events are related to medicines. And if you look at the cost of the healthcare, 60% roughly, for various countries it may differ here and there, but roughly it is medicines comprise about 60% of the cost of healthcare. So that is why we need to be worrying about these medicines. And errors happen because of lack of concentration, because there are similar drug names, or the users or the various stakeholders, doctors, pharmacists, nurses, they may be inexperienced, or they have lack of knowledge, or there may be errors in reading the medication orders or wrong assumptions. So that is why harm happens to the patient. Now, this is a typical case of prescribing. Generally nowadays the trend has been using more and more medicines. You may have heard of polypharmacy. What is polypharmacy? Where you polypharmacy is where you can use a single drug or two drugs to manage a patient, but you use several different types of drugs to manage a single condition. Here is a case of simple abdominal pain with vomiting, young patient, no other problem, but you see that there are 5 different types of medicines. By looking at, if you look at the rationality or the logic behind each of the drugs prescribed, you will realize that perhaps the doctor did not make any diagnosis. He was trying to hit anything, what are the possible causes of abdominal pain and vomiting, and he's trying to address this by. And another scenario is that we are relying so much on the medicines. A patient comes to you and he comes back that this drug, after taking this drug, I'm feeling unwell or uneasy, or it is giving pain in my stomach, and we have started trusting in the power of medicine so much, and that we say that no problem, I will prescribe you another drug. So that's how, if you look at polypharmacy has become a big problem. Another problem is that we are overusing medicines, misusing medicines, and one particular class of medicines for which we need to be really very careful is about the misuse of antibiotics, overuse of injections. There are problems associated with these. I will enumerate what are those problems, and I call this as a global epidemic of irrational use of drugs. It is not only that in India or in Tanzania or Indonesia or all over the world, globally this problem is being faced. So it's a global epidemic that people are overusing medicines. And if you have to describe if everything is normal in our body, for example physiology, if you talk about breathing, circulation, nervous system, if everything is normal in the system, we call it physiological. So similarly, if you take the example from here to prescribing, and if anything goes wrong with the use of medicine in the prescribing, it is called irrational prescribing, is called pathological prescribing. So that means there is something wrong. When we are using antibiotics for trivial viral illnesses, which are otherwise self-limited, will get better on its own, need only supportive treatment, but we try to, do this, fix them by using antibiotics. We know that antibiotics do not work on viral illnesses. Most of the common cold, diarrhea cases, I believe you also see most of these cases in your outdoor department. They don't need antibiotics, but we do treatment. So that because of this problem, there is a rising antimicrobial resistance. The germs, the pathogens, microbes, they are becoming resistant. The existing antibiotics are not working on them because they have devised mechanism to survive even in the presence of these antibiotics. So as a result, hospitals, they are fostering life-threatening infections, which are not easily treated with the available antibiotic. And if you look at the extent of the problem of misuse of antimicrobials and AMR crisis, the two most important hit regions are Africa and in Asia. So we have the highest number of cases of AMR cases. Healthcare associated infections are really a big threat in these two regions, and in by 2050 the AMR could cause worldwide 10 million deaths. And this would be much more than the COVID deaths. We all felt the impact of COVID because it hit us like a tsunami. But this is a silent pandemic. AMR is a silent pandemic. We are not realizing, but this will kill much more number of patients than anyone else. And if you look at the comparative mortality due to AMR, it would be much more than any infectious disease, road traffic accidents, tetanus, cancer. So this is the global figure that we have. So we need to be really worrying about the misuse of antibiotics. Then another problem with the prescription or the use of medicine is their incorrect use. You know that you need a medicine for the treatment, particular medicine, but we don't use it in a proper dose or duration or frequency. And we use multifold, more than one drug for the same condition, which could be easily treated with one drug. Unnecessary expensive drugs, when we write this, for example, tonics, multivitamins, for malnourished child. For a malnourished child, nutrition is much more important than, but we try to fix it with expensive tonics or multivitamins. This is again inappropriate use of drugs. Here is the prescription. This is from India, but I believe the situation is more or less similar in other continents, because we are using more than one drug for each, and for the side effects we add another drug. So the number of drugs the patient is receiving is increasing day by day. So polypharmacy is the largest problem. And if you look at the studies, you will find more the number of drugs prescribed to a patient, greater is the harm, due to there are more chances of patient getting medicines in error. So it would result in greater harm to the patient. This is also called a cascade prescribing, where you start with the original condition and then you keep on adding medicines to treat the side effect of that medicine. So for example, here a patient is a diabetic patient. You start with ACE inhibitors. The patient develops the side effect of hyperkalemia. You add diuretics to this. Then because diuretics, they worsen the diabetic control, they disturb the diabetic control, then you add another anti-diabetic drug. These diuretics also affect the uric acid level, so another anti-uric acid. So like this, a drug is being added, which is worsening the condition of the patient. So then another global problem that we have seen is the misuse of proton pump inhibitors, omeprazole type of drug, pantoprazole, rabeprazole. This is used for the to treat the acidity problem. So but many people use this, once the patient is put on this medicine, they remain on this medicine, and this is being used thinking that this is a harmless medicine. Now the point I'm trying to make here is that even the so for looking innocuous medicine like omeprazole, it also has many adverse effects, side effects in the long run. So that is why we need to be concerned about use of these PPIs. Another problem in which will also called irrational is underuse of medicines. On one hand, we are overusing medicines. When not needed, we are using it, but underuse is equally a pathological problem, is equally irrational use problem. For example, asthma patient, or if hypertension patients, many a times even the prescribers, because these are lifelong illnesses, and once the patient is put on medicines, usually are required chronically as far as the patient is living. So many people think that they try to defer treatment as far as possible. So underuse is also irrational use of medicines. Failure to make vaccines available. Vaccines are very effective to control many infectious diseases, but if we, instead of vaccine, we go for the medicine treatment, using medicines in the wrong dose, duration, using medicines which are not efficacious, or which are not safe, or which are of unproven efficacy, also qualifies for irrational use of drugs. The common medicine problem, use related problem, is that the selection is not evidence based. So we need to be using only those medicines which are efficacious, safe, suitable, and at the lowest cost to them. And the treatment guidelines are either not there or not used, or many times we are using newer and expensive medicines in our enthusiasm. COVID time, we see there are a lot of many drugs, remdesivir, there are many other drugs which came in, for which we did not have any experience of using, efficacy, safety, but because during COVID pandemic time, we were panicking, we were helpless, so we use them. But there are many other examples where newer and expensive medicines are used. And also there is a rampant use of combination products, when FDCs are fixed dose combinations, where 2 or 3 different molecules are put it into one pill, fixed dose. Usually this is used in cardiology. For example, when you combine clopidogrel or atorvastatin, because these patients need all these medicines, so they will combine all of these in one pill, and on the pretext that this enhances the compliance to treatment. But besides this, you will find that there are many combinations which are available in the market, but which are not, there is no logic behind those. And many times these are pushed very heavily by the pharmaceutical industry. They mix up step-up therapy. Step-up therapy is, when you may start with one drug, and as the patient responds, or you see that the patient is not responding, you add another drug, third drug, fourth drug is added. This is called step-up therapy. But whereas combination therapy is that you right from the beginning, you start with 2 or 3 or 4 medicines. For example, diabetes, hypertension. Nowadays, people start with 2 antihypertensives in the first go. So this is called combination therapy. So this is okay if it is needed, but usually one should practice step-up therapy as the patient, depending on the patient's response. But these fixed dose combinations are promoted by the pharmaceutical industry by overrating the patient convenience, that it is easy to take 1 tablet rather than 3 tablets by the patient. But it has its own pitfalls. The other side of FDCs is that you may not be able to effectively adjust the dose. It has increased toxicity, or it may have abuse liability as well. Many of the cough syrups, if you see, they have these opioid derivatives in that, and they are very, very addicting. We are all aware of the hard addiction to the drugs of abuse, but cough syrup is one good example of soft addiction, where you don't even get to know, and your patients become addicted to this, and they may drink bottles of cough syrup because they have these opioid derivatives in them. So there are problems associated with this, and about 10% of the prescription today, they trigger a concurrent safety alert because there is a drug duplication, there is a drug-drug interaction, or a wrong drug is being given for that age, or dose is not properly like that. Besides this, illegible handwriting is another problem which is causing harm to the patient, and second guessing by the pharmacist. At least in my part of the country, people believe that the pharmacist can read everything. Even if the doctor has not written legibly, here are few prescriptions I have shown here. Hardly anything you can make out, and people think that the pharmacists know about all the medicines, they can read it correctly. But I believe you will also agree with me, the pharmacists are also making guesses about this, which may be correct, may not be correct, and especially if the prescription is not written properly, drug name abbreviations are written, dose is not correct, written properly, decimal is not used properly. So the description given on the prescription about how to take medicine is not properly. Besides this, drug administration problems are also there, which also contribute to the patient safety. Simple instructions like shake well, if it is not done, it can lead to problem. It can lead to underdose or overdose. Here, very good example is insulin preparations. You find that pre-mixed insulin, they are cloudy preparations, and unless you shake them well, this will not be uniformly suspended, and it can lead to overdose. Phenytoin is another example. Crushing enteric coated medicines, or crushing modified release preparations, again can lead to overdose toxicity. So there are many such problems where drug administration errors can happen if the sublingual tablet is not is allowed to be swallowed. The mode of action of absorption of sublingual will be defeated if the patient is swallowing. And if nowadays we have meter dose inhalers available, but if the patient is not told how to take these inhalers properly, again this can lead to administration errors. So the point I'm trying to make here is that if you want to assure quality and safety, if you want to prevent harm to the patient, although we have made impressive progress here, but still there are many problems which continue besides irrational prescribing. The quality and the safety of the medicine may be compromised when it is manufacturer, substandard drugs are produced or spurious drugs come into the market, or the supply chain allows unsafe and sometimes dishonest practices during transport and delivery, and if the regulatory capacity and enforcement are insufficient. So there are, several potentials here for medication errors, because there are too many different types of medicines which are available. Many of them are freely available over the counter. There are problems with the nomenclature, labeling of these medicines, and if this is combined with illegible handwriting, and if the user is not having complete knowledge about how to use these medicines properly, because they have a similar clinical use, can give rise to many medicine related problems. There are many look-alike, sound-alike medicines which are available. So I understand there are many pharmacists here, pharmacy technicians are also attending today. You need to be really very careful about the look-alikes, and this is not this is again a global problem. There are these look-alike, sound-alike pairs are available in almost every country. The number may be here and there, less or more, but this is there. They very commonly seen with injectables, but even the oral preparations, tablets, also have many look-alike. So one has to be really very careful about when you're using these medicines, dispensing these medicines. Look-alike, sound-alike medicines. You have look-alike, sound-alike vaccines as well. For example, TT, they are sounding similar, and the diluent, where you store them, the diluent sometimes comes with the vaccine, sometimes they are separate, sometimes they need to be stored along with the vaccine, sometimes they can be kept outside. So you need to be really very careful while dispensing these medicines, especially the look-alike medicine. Now, because the harm caused by these is tremendous, again, these are the global figures, and they have converted this into, we kill 20 to 30 patients per hour, and this is much more than 7-10 Boeing going down every week. So, if you, number of patients, there are many more. So, the point, by giving this figure, we are trying to say that the hospitals sometimes are more dangerous than air travel, because the medicines are not used properly. The reports of medication errors are again globally reported. It happens all. If you were following news, one nurse from UK was sentenced to jail for about, I think, 14 years or 15 years, because she gave look-alike medicine to a patient, and that patient died. So that nurse there was a lot of hue and cry about this in the news in UK. And if you look at the size of the problem, this has become the third leading cause of death. This is a report in BMJ in 2013 from United States. Now, if this is the kind of situation in US, we are all working in a low and middle income countries, where our healthcare systems are as developed as in US or any other developed country. So if the size of the problem over there is this, we can expect, the size of this in our own country here. Although these are the news items from India, and news as usual, they make it sensational. So they attract a lot of public attention. And the second point I'm trying to make here is that the mistakes happen are reported by all stakeholders. This could be a doctor, it could be a pharmacist, it could be a nurse. So one can't live in that kind of situation. No, it's only the doctor, who need to be worrying about this. Errors can happen anywhere, and we are all working for patient safety. And the first principle in medication management is first to do no harm. If you cannot help the patient, you cannot cure his condition, fine, but do not cause any additional harm to the patient. So now we have seen that there are inappropriate use does not arise from one single root cause. There are many more complex issues and involved which need coordinated actions. So this could be a policy, legal or regulatory framework. It could be a drug supply system. It could be prescribers, dispensers, and their workplaces, and of course patients and communities have a big role to play here. Many a times the prescribers say that I use so many medicines because the patients are demanding for it, but this is a overrated reason or the logic given by the prescriber. Patients think that the doctors know the best, and if this is a vicious cycle. So we need to be breaking the patient's demand cycle here, because the impact of this inappropriate use is huge. It reduces the quality, increases the morbidity, mortality, leads to waste of resources. So it can lead to reduced availability, increased cost, risk of unwanted side effects, bacterial AMR, psychosocial impacts. This is again, although we don't give much importance to this, but patients then they rely on unnecessary medicines. Diarrhea, at least in India, all cases of diarrhea will be treated with an antibacterial agent and an anti-amoebic agent, whereas we know that 90% of the diarrhea is viral in nature. So because we've been using it, now patients also think that these medicines helped in curing their diarrhea, in controlling their diarrhea. So that's the kind of vicious cycle that starts. So doctors are inclined, because many a times they think if they want to portray their image as up-to-date doctors, and maybe they are out of curiosity because something new has come into the market. They want to use it, they want to see the new features, so they use it. But the overall impact is that there is a growing dependence on the private sector, because 50 to 90% of all drug purchases are private. Out of these, 2/3 are self-medicated. Around half of the patient, they buy only one day's supply because they don't have enough money to buy this, or they don't feel the need for completing the course of and then 50% of the people worldwide do not take medicines properly. So and we need to be worrying about this problem, because a few decades ago only infectious diseases were the problem, but now we are seeing that the non-communicable diseases are also becoming a big problem. Hypertension, diabetes, stroke, coronary artery disease, all these things are adding, and third, group 3 injuries are also increasing because of the road traffic accidents. So this is the figure from India, but the point I'm trying to make here is that now the burden of the diseases has doubled or tripled, so we need to be using these medicines properly. Now, when it comes to the role of various stakeholders, so up till now I was talking about the prescribers. Now, procurement also influences the rational use of medicines, because if you don't procure and make right drugs available at the right time for the right patient, it also encourages irrational use, inappropriate substitution of the drugs, inappropriate choice of the drug for that patient. So, but there are many procurement related practices which uh, uh, interfere or influence the, for example, if there are mistakes in orders, there are problematic suppliers, either they don't supply on time, or the quality of the drug supplied by them is not adequate, or ineffective strategies are there, there is no oversight, there is ambiguity in roles and responsibility, so coordination, collaboration is not done properly, and because there is no overview, lack of oversight, audit trails are not done, so procurement, undue delay in procurement can, hamper the entire public, make the entire public health system suffer on this account. And in many places I have seen, because there is no planning in procurement, because we know, especially for the public health system, the procurement cycle takes some time, and because there are various stages involved, and especially if you are importing these medicines from other countries, so there are regulations, the port site, all those problems also come in. So we have to be making realistic estimates of our procurement cycle time, lead time, how much is it, and then plan accordingly. But on the contrary, we see that most health systems are reactive, they are busy managing the crisis part, but the planning part is missing. So that can influence the rational use of medicine. And then supply chain management is a very, very critical aspect of drug management. But it is at the same time a very, very complex issue. There are many, nodes. There are many people involved in the maintaining the supply chain. Although this is the very simplistic depiction of what a supply chain looks like, but it is much more complex than what is being depicted here. And especially when you are importing, as I said, the biggest problem today, besides this coordination, regulatory requirements, vaccines or the items, drugs and sera, blood products, which need cold chain shipping. This is a very specialized task this day, so that the temperature is maintained throughout the chain. Counterfeit, how do you tackle counterfeit or substandard or spurious medicines? And the lack of visibility, track and trace in the supply chain, this is a very big issue. How much was manufactured, where is it being used, how much is being used, what is exactly for which condition or for which patient it is being used. This track and trace is becoming a big issue, especially for two group of drugs like antibiotics. We want to know where is it, because it is being used for both animal sector as well as human sector. So is it the animal sector who are overusing antibiotic, or the humans, and where in the humans, like that. So you need to track and trace. Similarly, opioids, the drug dependence, which drug is produced where, which region. So all these track and trace problems are there, and these are being faced by almost all countries. So these supply chain issues we need to be looking at, and they have an important role in rational use of medicines. Now, coming to the last part of it, strategies to improve use of medicines. There are WHO has given that 4 major strategies which can help in improving use of medicines are educational, managerial, economic, and regulatory. Regulatory is that you make a restrict choice, you make effective regulation, you don't allow over-the-counter dispensing, or you regulate the user, you may ban a drug, or don't allow fixed dose irrational combinations. So those are regulatory. It has a great impact, but the problem is always with the implementation. Economics, that we can look at the incentives. what is that, making people write more number of drugs or dispense more number of drugs. Managerial are very effective, that you try to guide clinical practice by standard treatment guidelines, aligning drug supply with the selection of medicines, and last is educational, like we are trying to do the capacity building today by having this session. We are trying to inform about the problem, the magnitude, the impact of this problem, and we are trying to persuade you to use these medicines properly. So for any, if you want to use these properly, selection is the, basic main foundation. If you select your medicines properly, the rest of things would go properly. If you have good procurement practices, pooled procurement is, will give you economies of scale, less cost will be there, good quality medicines combined with good quality use of these medicines, research and monitoring on use of these medicines, how, when, where, who is using. All these things can help you, and training programs, this will help you in improving the drug use. And pharmacists,
Sharma?
yeah,
Yeah, sorry, we're just running a bit out of time, so I would
Sure.
request you to, yeah,
Okay.
we can wrap it up in the next 5 minutes. Yeah, thanks.
Okay, fine. I'm about to end. Pharmacists are the vital link between the doctor and the patients. So pharmacists may be working in hospital, clinic, or a community, and dispensing is a very important part. And you can, as a pharmacist, you can ensure that the medicines get to the right patient in a right dose, right dosage form. And pharmacists have a huge role in promoting rational use of medicines by educating the patients about use of these medicines correctly, because most of the misuse problems arise because the patients do not have good understanding, and this will help us in increasing the clinical outcomes. Pharmacists can help in removing the barriers, the education, language barrier, system related barrier. So you can use the pharmacist patient communication is very critical here. Packaging of the medicines, labeling, written information to the patient, all these are the ways to enhance patient education. And although the dispensing in the public and private sector varies, but at the heart of this is the patient only. So pharmacists can avoid these dispensing errors, by taking care of the look-alike, sound-alike, packaging, labeling problems. Pharmacists can strengthen effective drug management. They can overcome chronic shortages, combat problems with the quality of medicines, inventory. The pharmacists have a big role in improving the service. How much inventory to be kept, because there are benefits and the costs related with maintaining the inventory, and depending on that you can make a decision about whether you want a pull system or a push system, just in case or just in time, whatever is needed, pharmacists play, because there is a seasonal variation also. So you need to be tackling this aspect, because the drug demand may change because of the season, and maintaining records properly, inventory records is a prerequisite. So pharmacists have a great role in maintaining accurate records here. Using selective inventory control methods. There are different methods available. So pharmacists, if they use these, two are commonly used, VED and ABC. Today there is not much time. I cannot go on into the details of these, but if you use these two selective inventory management tools, you will be able to make rationalized decisions about this. Storage of the drug, because much of the potency of the drug is affected by the storage conditions. If the temperature in the store is not properly arranged, or the drugs, look-alike, sound-alike drugs are not properly arranged, you can use auxiliary label, organize stores so that errors with medicines are reduced. Monitor periodic checking of the temperature and humidity is very important, because if you feel hot, the drugs also feel hot. So most of the drugs require a room temperature of not more than 25 degrees. So, and many vaccines need to be maintained cold chain. So pharmacists again have a role, because by just looking at the vaccine vial, you cannot say that this is potent or not. So that chain has maintained. Quality indicators need to be tracked and traced and followed. And worldwide, everywhere, there is a problem with the space for the stores, pharmacy stores. But we need to, pharmacists need to look into it, whether they need to dejunk or expand, because we may not have that kind of space. So keeping up with the current pharmacy practice, new drugs which are coming in, managing, supervising, and training of support staff can help us in great way. So I would like to conclude here, making medicines available is a matter of justice these days. Everybody has a right to medicines and healthcare, and access to this is a human right. This is a public good that we need to be following. It's not a question of individual, and all of us have a responsibility to make. And particularly, if I need to talk about the responsibility of the pharmacists, they are definitely, as I told you, procurement is important, supply chain, then prescribing. Sometimes so many health systems, they do not have any registered medical practitioner there. So pharmacist is the only available professional there. So they need to be, doing this properly, following, communicate. They need to, pharmacists are in a unique position. They need to talk to the doctor on one hand and patient on, so they are a very important link. And if you use standard treatment guidelines, economics, and manage properly, do research, pharmacists can effectively come up with the research on these and consumer education. This will help in promoting rational use of drugs. So I think I have said this. You can use there are many resources available. If you go to the internet, you will find the guidelines. Your own country may have the standard treatment guideline. There are good practice, pharmacy practice guidelines are there. Then similarly, good nursing practice, for nursing pharmacology, the guidelines or the guidance is available. You can use any of these to promote rational use of medicines.
Wow.
Thank you.
Thank you so much, Professor Sangeeta. We all learned a lot today, and we really appreciate for this very insightful presentation. Maybe I can also respond because I saw some people asking for the materials for the presentation through the chat box. Just be assured that it will be shared to you, so don't worry about it. You have the presentation, and you can also have the clips to YouTube, so you have all the access to this webinar materials and the audios. So maybe we can go, because time is not on our side. We will not even allow you, Sangeeta, to sip some water. So I will just have to take up the questions. There was a question that is asking, is rational use applicable to analgesics such as paracetamol?
Can you come again? I didn't follow.
Okay, that is, I think it's the rational use. The rational use. Is it applicable to analgesics such as paracetamol?
Yes, there is a misuse potential for even essential medicines. Paracetamol is an essential medicine, but if you use it in a wrong dose, wrong frequency, for wrong duration, for wrong purpose, again this will be qualified as an irrational use. Similarly, another example is amoxicillin. It's a very basic antibiotic. very basic antibiotic used for treatment of many infections. But if you use this antibiotic for a viral illness, this is an essential medicine, but if you use it wrongly, it has a misuse potential. So all drugs, basically all medicines have a misuse potential if not used properly.
Okay, thank you so much. Professor Andy, you are welcome.
Greetings.
Yeah,
I think go ahead with the questions and I'll just chip in when necessary. Yep.
Thank you, thank you. So there was also a question that is asking if are there standard tools which will help us to improve rational use of medicines in low and middle income countries?
These are standard treatment guidelines are available. Many countries have developed these guidelines, and globally they are being used for promoting rational use of medicines, but they are called guidelines. They are not the law. As the name suggests, this is the guideline. They are voluntary. It is for the people to use this. But I take it in the other way. It is good to follow standard treatment guidelines, but if you are not following standard treatment guideline, there should be a good enough explanation why is it that this standard recommendation given in the standard treatment guideline was not followed for a particular patient. In developed countries, Andy is there. I think you can substantiate this. Right from the day one of their clinical practice, everyone is given this standard treatment guidelines, and they are expected to adhere to these standard treatment guidelines, because all the reimbursement, all the coverage, insurance coverage, everything is related if they are following these standard treatment guidelines. Because it's very difficult for any country, even well-developed countries, to have open-ended prescriptions where the cost it can go up to any extent. Nobody can afford that kind of a system. So everybody wants, and more so for the patient safety, that no harm should be caused to the patient. Patient should be appropriately managed. It is important that people should follow standard treatment guidelines.
Yes, Professor Andy, do you want to add something there?
Yes, indeed. In addition to the standard treatment guidelines, there are WHO guidelines on how to implement your rational use of medicine program. So the key place is the standard treatment guidelines, but there's overall rational use of medicine planning available in WHO documents as well.
Thank you very much. We have another question that is, because in your presentation, Professor Sangita, you talked about the collaboration between the physicians and the pharmacists, okay, as far as improving the rational medicine use, yeah? So someone wants to know what are the strategies that we can adopt to improve this collaboration between the physicians and the pharmacists so that we ensure rational use of medicines.
The selection of medicine is a very, is the cornerstone of all the improvement in medicine use. And if you want to say that you want to promote rational use of drugs, selection of evidence-based medicine is the first step. So here comes again the role of pharmacists, because they are the custodian of medicines in the hospital or in the community setting. They know what is the usage being going on, so they can give you a good guidance on selection of appropriate essential medicines for the hospital or any other system. Secondly, the second major disconnect which is observed is, you may have a very good evidence-based selection of essential medicines, but when it comes to procurement, they are not linked with each other. See, it happened in in my own country. We had a very good list, we had a standard treatment guideline, but the procurement cell was procuring something else. So unless we have alignment between selection, procurement, and use, we cannot expect any improvement taking place in the use of medicines. And then pharmacists, again, usually the doctor don't have much time, especially in low and middle country, because of the heavy patient load. They don't have much time to explain about the diagnosis, about the medicines to the patient. But the pharmacist is in place to explain how to use these medicines correctly, because much of the misuse problems come because patients do not know how to use medicines correctly. So pharmacists have a very great role. They can improve upon patients' understanding about the drug use related instructions, so that they complete treatment as prescribed by the doctor.
Thank you very much. Maybe I can chip in with a follow-up question. When we talk about quantification, do we see any opportunity when we are doing the quantification of these medicines to ensure that we are improving our rational use of medicines?
Yes, quantification is another big issue. Even if you select them properly, you procure, but if you do not know what are your exact requirements, then you will not be able to use them properly. I'll give you an example of malaria here. If you do not have chloroquine available, then how will you reduce the mortality and morbidity because of malaria? Many times it is not the funding issue, it is not the finances, it is not the procurement. It is just because we do not know what is exactly our need. How much do we need? If you are just depending on the past consumption reports from the registers, then our forecasting will not be accurate. And if it is not accurate, and if you are not able to provide a basic drug for the management, then you may label patients as chloroquine resistant, because simple chloroquine was not available. People were not able to treat them, and that's what happening. And then people interpreted it as it is the resistant malaria which is causing increased number of deaths.
Okay, thank you. Professor Andy, do you want to say something there?
Yes, on quantification, you can't have rational use if you don't have enough drugs. So quantification is a key area. It's often neglected. And one of the largest drivers of irrational use is not having the product. So you're using something else because you don't have the product. So good quantification is an essential part of rational medicine use.
Thank you very much. Maybe we go to the last question. The question asks, what tools can countries use to generate evidence-based systems for selection of medicines for use? What tools can countries use to generate evidence-based systems for selection of medicines?
There is a, WHO has essential medicines list. The criteria is being given. Because there are a number of drugs now which are available. Even within class, there are a number of medicines. So they have given that you need to select medicines for your health system based on 4 criteria. The first, the most important is efficacy. The drug, the medicine which you are selecting, it should be efficacious for this. It should not be just in case, this medicine. It should be evidence-based. There should be reports on that efficacy. Then second important issue is safety, that the drug should be safe. There should not be any unacceptable adverse reactions associated with it. Then third aspect which we need to look into is the suitability, whether there is a suitable pediatric dosage form, or is it suitable for elderly or not. Last is the cost part. As the rational drug use says, it should be at the lowest cost to the patient, individual, as well as the community. So cost, your interpretation may vary, but generally it is considered when it is a chronic treatment, it should, because many people are not able to afford, or they don't adhere to it because they cannot afford this treatment. So that it should be, cost should be lowest. But in acute setting, you give most importance to the efficacy part and the suitability part. So you need to balance on these 4 criteria for any healthcare system. If they use this yardstick, it should go well with the selection of medicines.
Thank you. Professor Andrew, can you conclude on that?
Yes, there is WHO guidance on how to conduct the Drug and Therapeutic Committee, including use of evidence-based, such as Cochrane reviews for new medicines and full economic assessments. It's not necessary that countries themselves undertake these complex assessments. WHO has largely made them already. So it's how to manage the Drug and Therapeutic Committee to follow the existing WHO guidance, which is there. And that comes down to the essential medicine list again.
WHO, taking his point further, WHO, they have made a model list. They have identified, because, utilizing the available evidence is a very critical task, needs expertise, skills, time, which may not be readily available with all the healthcare systems. So that is why they have made a model list. So countries can then adapt it to their requirements. They can choose from this model list that what is best for their healthcare system.
Thank you very much. So I know we still wanted to hear more and more, but time is not on our side. So thank you very much, Dr. Sangita. Yeah, you did justice to us. Thank you very much. Thank you very much. I'm seeing people appreciating a lot. Someone said she's going to be an ambassador for rational use, from this evening. So this is really, really good. Like someone has already decided to change and to be a pioneer for this. Thank you very much, Professor Andy. It's very nice to have you. Always is nice for your insightful contributions. We really appreciate for that. And I thank all the participants. So now let us finish with the poll. Please give us your feedback on this webinar because we expect to have more and more of this kind. So we'll appreciate to get your feedback on how you perceive, did we meet your expectations? So we want to hear from you so that we can plan better for the future. Please, thank you. We'll appreciate if all of you will go through the poll. Thank you. Thank you. Thank you. Yes, 50%. At least we should get 70%. Yes, please. Yes.
Hello.
73. Okay. So we can end there. At least we get more than 70% response. Can we end the poll now?
Yes, we can.
Thank you.
Yes,
so we have from the poll, we have 78%, sorry, 97%. The participation was 78%, but now when we go to whether the webinars met with your expectations, 97% indicated yes. And in terms of rating of the webinar from a scale of 1 to 10, 85% rated it from 8 to 10. Thank you very much. And we would like to know if you'd be interested to join us for the future webinars, which are skill-based. And 99% indicated that, yes, they are interested. This is very good. And we wanted to know if you have taken any courses with Empower School of Health. And now about 74%, they have not taken any courses. And 12%, they've taken the diploma, and 15% they've taken the certificate course, while 7% have a face-to-face courses. So this is a good feedback, and I just wanted to tell you that if you go through their website, you can always get a link and see the potentials for skills upgrading through self-paced learning. Yeah, and they have a postgraduate diploma, which is very useful even for non-pharmacists. Yeah, it's very useful for non-pharmacists, so you can go through there. Thank you very much for this positive outputs, and we expect to see you in the near future when we have more of this kind of skills-based webinars and other interventions. So just to let you know is that you get your certificate within 24 hours after we finish this webinar, so it will be sent automatically. So don't worry, you get your certificate of participation. And for those who are Tanzanians, we will see how we can send the presentation to the Farmers Council and see if they can be able to evaluate it and see the possibility for getting your CPDs. So thank you very much, yeah, for participating, and we always keep in touch with you. Thank you. Thank you, Dr. Sangita. Thank you, Professor Andy. Thank you, the Empower team. Thank you very much. And this is the end of our webinar for today.
Gladys,
Thank you.
Can we just have everyone just switch